this is a new program, new webinar launched by the Sri College of Pediatricians. Actually, initially we just started the Pediatricians Forum. At the same time, our incumbent president, Shyam Rajendra, suggestion, why can't we launch a series of this type of webinar with our senior people? So then instantly we all were agreed to launch this. So these are our pearls. So it's real legends. So there are a lot of things to be learned from these legends. So I'm sure juniors as well as the working pediatricians all still can learn from these legends of yesteryear. So I would like to invite Professor Shaman Rajendra to give some opening remark before introducing our speaker today.
Good evening, ladies and gentlemen. I'm very pleased to introduce this new webinar series by our senior colleagues who are, most of them are our teachers. So when Chan and myself one day were discussing in the president room, what can we do apart from this usual work, then Chan suggested why can't we start a program on about giving lectures by young pediatricians, saying young pediatric for. Okay, I said, okay, that's good. So similarly, we can learn from our seniors. So our teachers who are now, some of them are trying to rest and, hide from us. And some of them are still, joining us on a regular basis. So this webinar today is one of those, to begin with. We have a great pleasure to have our, most respected teachers, one of our most respected teachers, Professor Sanath Lamabadusuriya, to start this vintage pediatric pearls. So can we, can people switch off their mic, mute their mics, please? It's a great, very sincere request to mute all your mics, right? Especially when Prof is speaking, I think we need to do that because all of us are really like to listen to him very carefully. So this is the product of that discussion. So we are very grateful to Prof Lamabadusuriya joining us today, and my able secretary Chan is running up and down with so many webinars and so much of work trying to organize this. So I won't take much time. Thank you very much for joining. We have 400 odd people to listen to your lecture, sir, today. So without much of a delay, I would like Channa De Silva, my able secretary, to introduce our speaker. Over to you, Channa, to introduce Prof. Lamabadusuriya.
Thank you, sir. Thank you very much. And as all of our audience, they don't need any introduction about our speaker, Professor Lamabadusuriya. So he was an emeritus professor of pediatrics and former dean of the Faculty of Medicine, University of Colombo, and is a founder professor of pediatrics in University of Brunei. He did a lot of service to the development of pediatric department in the University of Brunei Faculty of Medicine, and he was senior professor of pediatrics University of Rajarata. They are also a pioneer to develop that university, and now he is doing the same work at Sabaragama also. And he was past president of Sri Lanka Medical Association and as well as Sri Lanka Pediatric Association. So he's a consultant pediatrician. Most importantly, he is a very good clinician, as we all know, very good teacher as well as a very good teacher. When we currently modern medicines, we are mainly focused about a lot of investigations, a lot of other things, but still we have to learn a lot of things from this type of senior, especially legends in this our country, especially the value of clinical science, physical science, history taking, and physical science. So Professor Lamabadusuriya will discuss about the value of clinical science in medicines. So it's very great pleasure to have this. Over to you, sir.
Right. Get this. These won't appear there.
Yep.
Okay. Good evening, everyone. First of all, I would like to thank the President of the College of Pediatricians, Professor Shaman Rajendrajit, for extending this invitation for me to deliver this lecture tonight. And also my thanks go to Dr. Channa De Silva for all the hard work he did behind the scenes to organize this lecture. Now, I have chosen this topic. I think this is appropriate for a patient belonging to my generation. And I think it's an important message for the next generation of pediatricians and clinicians. I have chosen the topic, the value of history taking and clinical science in modern medicine. How do I move this? It is Prabhakaran Thirumale who said that medicine is a science when you study, but it becomes an art the day you start the practice. Yeah. And it's Voltaire who said that the art of medicine consists in amusing the patient while nature cures the disease. So what I want to emphasize is that a good physical examination, wait, go back. That a good physical examination combined with a comprehensive history, it most often leads to a diagnosis. And investigations are done only to confirm the diagnosis. In modern medicine, nowadays, investigations are requested indiscriminately and later there are difficulty in interpreting the results. Now, what about the sequential history of evolution of investigations? It was back in the 17th century that laboratory investigation started evolving and progressing rapidly. Then in 1895, Wilhelm Conrad Röntgen invented the X-rays. Then in 1950s, between 1950s and 1970s, Ian Donald introduced ultrasounds and CT scans. MRI scans were introduced in 1971 by Lauterbach, and PET scans in 1973, Edward J. Hoffman and Michael E. Phelps, and in 2000, David Townsend and Ronald Nutt. Now, why is a good physical examination important? That is because then investigations could be targeted, investigation could be interpreted in the context of the patient, and sometimes investigations could be wrong sometimes. And results of investigation sometimes take time to become available, and management of decisions need to be taken based on clinical findings. The example I have quoted is a febrile UTI in a 1-year-old child, because if you delay giving intravenous antibiotics to a child who is having a febrile UTI, he may have renal damage, and 30-40 years later may end up with chronic renal failure. So that is why you have to take quick decisions pending investigations sometimes. Sometimes even in a neonate, on the first day may have high fever. Then you request for investigations, including a CRP. And then you start on antibiotics until you get the blood culture reports available. So those are two examples. Now, I would like to relate some histories that I come across during my experience. I would like to remind the generation that I joined the Department of Pediatrics as a lecturer on a very auspicious day, being the 1st of April, 1969. So I have completed 52 years of academic pediatrics. Now, this child presented to me in May 1992. This was, I returned to Colombo from Ruhuna, in September 1991. And in May 1992, a classmate of mine, the late Shibli Aziz, who was a state council at that time, gave me a call and said a colleague of his wants to show his child to me. And where do I see patients? So I said, I see patients at our local hospital and Central Hospital. Then he said, well, it's not that simple because this patient is under the care of another pediatrician. Then I said, according to our medical ethics, I can't come and see the patient unless the pediatrician wants a second opinion from me. Then I asked who is the pediatrician. Then he said it's Priyani Soisa, Professor Priyani Soisa. Then I said, of course, in that case, I would be the last person that she would ask for a second opinion. And I left the phone. The phone rang again the next day and said, my colleague, another state council, insists you should see the patient because her daughter had been under the care of Professor Priyani Soisa more than 1 month in a private hospital and she is not improving. Then I said, all right, if that's the parents' wish, ask them to discharge the patient and preferably admit to another hospital. So when I finished seeing my patients at our local hospital one evening at about maybe 9:30, 10 in the night, there was a message that there was a new admission upstairs. So when I went up to see, this is a patient and his father, Riyansi also Kulratna, had discharged the patient and readmitted and crossed the corridor and admitted to another room. When I went in, Suhani was there having generalized coriform movements involving the face, the arms, and the legs. And when I looked at the notes, she was being treated as for a case of rheumatic chorea from mid-April until I went to see her. Now, when I saw this patient, my mind went back to the medical student days. When I was doing an appointment with Dr. Stella De Silva, she demonstrated a case of rheumatic chorea and she demonstrated all the physical signs, starting with the jack-in-the-box tongue, hippus, that is alternate contractions and dilatation of the pupil, the dinner fork deformity of the hands when you stretch the hands out, and then when you ask the child to put the hands up, then the palms are turned outwards, and of course, the tendon jerks, which are pendular. I remembered that. So what I did was I observed the coriform movements and I did the tendon jerks. And these are very brisk. And I made a note in the BHT and put 2 asterisks. And I told Riyansi, I don't think this child is having rheumatic chorea, but I would like to review her the next morning. I attempted to look at the fundus by the oscilloscope. She was struggling and I could not visualize the fundus. Next morning, I came and examined the child to see the same coriform movements and the brisk tendon jerks, bilateral tendon jerks were there. Then I told her, Riyansi, that I think that there is a problem in the brain and I would like to do an expensive investigation. He asked what it was. At that time, only Navaloka Hospital had a CT scanner. I said, I want to do a CT scan of the brain. He asked how much it would cost. I said, about 10,000 rupees. He said, please go ahead. I did it. And it was reported by Newton Jayaratka, senior radiologist. He said, there's a brainstem glioma at the base of the brain. He suspected a brainstem glioma because there was a space occupant lesion at the base of the brain. Then I referred the case to Lal Gunasekara, who was working in Colombo at that time, neurosurgeon. And he said, it's inoperable. Then Riyansi also Kulratna decided to take Suhani to the London hospital in England. And they said the same thing. Suhani came back and she died. A few weeks later, she died. Now, what are the lessons learned? First of all, the importance of a thorough history and physical examination. Here, the physical examination, the clue was the very brisk bilateral knee jerks. And mind you, when Riansi and his family were holidaying in Neurocutaneous during the April vacation, Riansi noticed that Suhani was having a limp. Then they aborted their holiday and returned to Colombo and consulted Professor Priyani Soisa. Being a New Year vacation, I think she was probably the only pediatrician available during that break. She diagnosed rheumatic chorea, told Riansi, you are living in an overcrowded area because she still lives in Grandpa's. And when you live in overcrowded areas, you get such illnesses, and said, I have rheumatic chorea, and admitted. Now, and continued to treat for 1 month as a case of rheumatic chorea. Now, the point here is the presenting complaint was a limp. Now, rheumatic chorea, as far as I can remember, as far as I am aware, it doesn't start with a limp. It starts from the face and it goes down. So the clue here was originally a limp. In other words, there was a problem with the lower limbs, not in the face and the arms. So that was the clue. So there was no regular review. The case was not reviewed regularly. And the patient's condition deteriorated and was under her care for 1 month. And most importantly, a second opinion was not sought. Because of the father was a state counsel, J.B. Pires, neurologist, was called, and through Bulla de Silva, because Bulla was married to, was related to J.B. So through that connection, Bulla de Silva was a state counsel at that time. J.B. had made an entry. He had not said anything about the diagnosis. He had requested for a skull X-ray and an EEG, and the same treatment continued. So that's the first case. Now, second case, I won't divulge the name. He was 36 years old. He was a senior lecturer in chemistry. He developed a right-sided low motor neuron facial palsy. It should read a low motor neuron facial palsy, not Bell palsy, on the 3rd of October, 1998. He was seen by a well-known neurologist who did not check the blood pressure. 1 month later, this person developed blurred vision while looking at DNA images. The eye surgeon found bilateral retinal hemorrhages. And the blood pressure was 220 by 140. Because this patient was known to me, the eye surgeon sent the patient to me, and I checked the blood pressure myself, and I hit the roof. Then I contacted Chandima Dimel and admitted him under his care to Navaloka Hospital. Later on, he was diagnosed to have a chronic renal failure due to IgA nephropathy, and he had a renal transplant in May 2000. Currently, he's working at a university in the USA as a professor of chemistry. Now, this thing about blood pressure being a cause of Bell palsy, low motor facial palsy, reminds me of a patient I had with beta thalassemia major when I was in Karapiti. That patient had a low motor facial palsy and also a phrenic nerve palsy on the same side. I wrote it up and sent it to the Archives of Disease in Childhood. And I thought that the nerves had got pinched at the exit points from the vertebral column due to the hyperplasia of the bone marrow. And one referee returned the paper, asked him one question: what was the blood pressure? And I sent a reply saying that the blood pressure was normal. So that's another instance where the referee wanted to know whether there was hypertension, which could have resulted in the low motor neuron facial palsy. Now, this I teach all my students, that whenever a patient with low motor neuron facial palsy, you must always check the blood pressure irrespective of the age. And it's the importance of carrying out a thorough neurological examination without rushing to a diagnosis, because low motor neuron facial palsy is so common. So that's my second case. What's my third case? This happened to be the granddaughter of a batchmate of mine. I can't mention names. this was my batchmate, who was a GP in Hangwell at that time, gave me a call and said, "Hello, Lama, can you do me a favor?" I said, "What is it, so-and-so?" He said, "My grandchild had got a problem. Can you see my grandchild?" I said, "Okay, come to Navaloka Hospital." So my friend came with his daughter, son-in-law, and the grandchild. And his daughter sat in the chair in front of me. And the complaint was that the child was having fits. And those fits involved generalized fits. The description was that of infantile spasms. And it was uneventful birth history, development of normal for age, and had multiple depigmented lesions on the trunk. Straight away, I made a diagnosis of tuberous sclerosis with infantile spasms, and skull X-ray revealed intracranial calcification. I teased my batchmate and friend, saying that he had the DCH Ceylon at that time. I said, "You should have made this diagnosis before coming to me." Anyway, my friend died, I think about 2 years ago. I went to the funeral parlor and I saw this girl. She was now about a teenager, and she was doing well in school. And I was very happy to see her so many years after I had made the diagnosis. So what are the lessons learned? Importance of pattern recognition. I always tell my students that the more cases that one sees during one's career, you will be a better clinician. And when I was a medical student, I was not fond of reading books. I spent much more time in the library, in the wards, than in the library, examining as many patients as possible. I had a group of about 4 or 5 friends. We used to go to the wards, and each one used to examine a case, and we used to present the case to the other 4 or 5. And they used to try and ask questions and tear each of us to pieces, and we took our turn. That's the way we learned our clinical medicine. And pattern recognition is extremely important, especially in pediatrics, because of so many syndromes. So more patients one examines, much better chance of a correct diagnosis when you see it again. And a good clinician is similar to a good detective. That also I tell the students. And quoting Sherlock Holmes and Dr. Watson. Of course, the modern generation of students, they don't know who Sherlock Holmes and Dr. Watson are. Case 4. A 4-year-old boy presented with a headache of 5 months duration. Common symptom. Treated by a GP for migraine. Unusual to have migraine at 4 years. That's another matter. Treated by another GP for sinusitis. Favorite diagnosis made by some GPs. Ophthalmoscopy revealed bilateral papilledema. CT scan of the brain revealed a frontal lobe tumor. He was successfully operated and made an uneventful recovery. So what are the lessons learned? Always perform ophthalmoscopy when a patient presents with a headache, irrespective of the age of the patient. If necessary, sedate the patient, but never with chloral hydrate, because that causes pinpoint pupils. In a child who presents at 7 months with bloodstained stools and vomiting and bouts of crying, you would suspect intussusception, and then you want to sedate the child. Chloral hydrate is ideal. But if you give chloral hydrate to examine the fundus, it will constrict the pupils, and even if you put eye drops to dilate the pupils, those won't dilate. So you'll have to sedate with something like promethazine or diazepam to look at the fundi. And carry my pocket diagnostic set with me always when I see outpatients. I never take chances. Next case, a 5-year-old boy from Kothaville, far away, presented with abdominal pain of 4 months duration. And I detected dextrocardia. But dextrocardia does not cause abdominal pain. I examined the abdomen. There were no signs. Then I requested for ultrasound examination of the abdomen. Probably I used to refer all the cases to Major General Sanjeev Munasinghe, presently Secretary Health, who is excellent radiologist who was trained in Princess Alexandra Hospital in Camperdown, Sydney. excellent radiologist. Unfortunately, he is too busy with his administration and he is not doing any clinical, any radiology work now. So Sanjeeva diagnosed left pelvic junction obstruction with hydronephrosis. Successfully treated probably by Ranjan Das with an Anderson kind of procedure. Another excellent pediatric surgeon, Ranjan Das. What are the lessons learned? Very easy. Dextrocardia does not cause abdominal pain. And in pediatrics, when you detect a congenital abnormality, always look for other congenital abnormalities in the other systems. That's the lesson learned. Number 6. And now one of the listeners would be very, very familiar with this case because I think he is participating in this lecture. A 9-year-old boy was given for the pediatric long case at the final MBBS exam in Ruhuna in 1984. That was the second batch of Ruhuna students. Patient with jaundice was admitted to the ward by a consultant. There was a senior lecturer at that time. He had seen this patient in the private sector and diagnosed as a case of viral hepatitis because this child had icterus. Now, when I came in the morning to select the cases for the exam, the registrar said, there's a child with viral hepatitis. I looked at the eyes, there was icterus. I said, that's fine, give it. So the patient was given. Then a student by the name of Sujiva Amarasena came for this case. He presented the case and he said, it's a case of paraquat poisoning. Both examiners hit the roof. I think the other examiner at that time was Nimal Fonseca. Hit the roof. And then we got up and we went to the station, patient. And Sujiva had detected icterus, buccal ulceration, and subcutaneous emphysema in the neck. And the last 3 signs were missed by the ward doctors, including the consultant who admitted the patient to the ward. So we asked Sujiva, how did this patient drink paraquat? Then he said, he has inquired, had drunk water from a pond using a discarded bottle because he was thirsty when he was returning from school, and the bottle was probably contaminated with paraquat. And that is how he got paraquat poisoning. Later on, when Professor Ope came for the MD exam, whenever he used to come for the MD exam, he wanted to visit my unit in Gaul. I don't know why that was. And I had half a ward at Mahamodara. So I gave various excuses and prevented him from coming and seeing half a ward at Mahamodara. This would have been embarrassing for me. But this time, when I moved to Karapete, I invited Professor Ope and this patient was in the ward. And I showed this case. And I told how a student had diagnosed this case of paraquat poisoning. Then he was shocked that paraquat was available over the counter because he said it's not available in England over the counter. And secondly, he said paraquat that is sold in England has an emetic in it, so that if you have accidental poisoning, the patient will vomit it in next to no time. So example of double standards. Anyway, later on, this case was reported by Suvijiv et al. As an unusual case of fatal accidental paraquat poisoning in Forensic Science International, volume 44, 1990, pages 22 to 26. So what is the lesson learned? There is no substitute for a thorough history and examination. Irrespective of who has made the earlier diagnosis, be confident to revise it even if you are a third-year medical student, if you are confident of yourself, irrespective of the circumstances. Be confident, have self-confidence, be sure of yourself. And currently, as most of you all know, Sujiva Amarasena is presently the Vice Chancellor of the University of Ruhuna. Congratulations, Sujiva. Next case, a 7-year-old boy was admitted with trismus to the ward. And he was being treated as a case of tetanus, because at that time tetanus was common. This also around the same time. But the response was poor. But he was observed to be drowsy as well. Now, a detailed history was taken by a medical student. He was also in Sujiva's batch. His name was Sanjeev Munasinghe. Later on, he became my house officer. Later on, he was already in the army. Later on, he became Major General Sanjeev Munasinghe, head of the Army Medical Corps, and currently Secretary, Ministry of Health. So that's how Sujeeva and Sanjeeva Munasinghe have ascended up the ladder. So sky is the roof for some of them. So he discovered that the patient had played doctor-patient game at home and with a friend at home in Moratuwa and had swallowed some tablets. So a psychiatric patient at home had been taking phenothiazines. Sanjeeva Munasinghe, without telling anyone, had tested the urine for phenothiazines with ferric chloride and it was positive. There was a purple ring at the interface. All that was done by Sanjeeva Munasinghe. Now, he as a budding radiologist, he was good at chemistry as well and pathology, clinical pathology. So, what lessons learned? Importance of taking a thorough history. Sanjeeva Munasinghe traveled from Karapitiya to Moratuwa to obtain an accurate history. And that is how we made the diagnosis. Major General Sanjeeva Munasinghe is the head of the Army Medical Corps and presently Secretary, Ministry of Health. Now, I want to tell you something about this second batch of Ruhuna students. I think Lama once reminded in his address at the Goa Medical Association a few days ago, Professor Lama once, that batch has the highest percentage of consultants for any batch in any medical faculty in Sri Lanka. So that's a record. That batch has 4 professors of pediatrics. The person who topped the batch, Sujeeva Amarasena, is the Vice Chancellor Ruhuna. UK Jayanta is the holder of the chair of pediatrics. IV Devasiri is the Dean of the Medical Faculty Ruhuna. Vasanta Karunasekar is a Professor of Pediatrics in the University of Kelaniya. Then there is MD Lamavansa, Professor Surgery, first person to do a renal transplant in a child. Recently, Ambassador to the USSR, and now currently Vice Chancellor, University of Peradeniya. So that batch had 2 Vice Chancellors. Then there's Jayan Mendis, currently Director and Head of the Department of Psychological Medicine at the KDU. And so many consultants, so many. And Jayan's wife, Sepalika, is a cardiologist. Sujeeva's wife is an anesthetist. So all have gone places. And I'm very, very happy that I was one of their teachers, extremely happy. So this is another thing, my personal experience. This was when I sat for the MRCP in June 1972, way back, and I had a patient with failure to thrive, recurrent bouts of diarrhea and recurrent respiratory infections. Very easy diagnosis. But mind you, they're the first case of cystic fibrosis that I have come across. I have not seen a case before that. Then they asked, how do you diagnose? I said, by doing the set electrolytes. Examiner said, how do you do it? I said, by sweat iontophoresis. Then they asked, how do you do it? How do you perform set iontophoresis? I said, this is the first case of cystic fibrosis I have come across. That was Ceylon at that time. I said, this disease is not found in Ceylon, and therefore I'm not familiar with iontophoresis. Then they asked me, has the patient got nasal polyps? I have forgotten to look at the nose. My theoretical knowledge reminded me that 10% have nasal polyps and 90% don't. Very confidently, I said, no nasal polyps. Then I said, the chest is clear. When I said the chest is clear, both examiners got up from their seats, didn't say anything, went and auscultated their chest. Didn't tell me anything. My heart sank when they gave me the chest X-ray because there was a spindle-shaped shadow between the upper lobe, right upper lobe and right middle lobe. And I thought this is a collapsed right upper lobe, but the trachea was central. I thought I had missed the collapsed right upper lobe. Trachea was central. Then I remembered seeing a similar X-ray long, long ago, and that happened to be an azygous lobe. Then I said, it's an azygous lobe. One examiner looked at the other examiner, and I heard that the other examiner was from the chest hospital, Brompton. He only said it could only be that. Then I was extremely happy. Later on, I met a Burmese doctor who had got the same case. He said that when he got that he had the lungs are full of Krebs, he failed the exam and I passed. Then there was a chap called Peter Barber, who was a registrar at Great Ormond Street. Later, when I went to work there, Peter remembered this case. I asked Peter, why did you give a patient without any physical signs? Then he said, Sanath, when we gave the case in the morning, that child had a lot of crepitations. But by the time you got the case, she had coughed up all those secretions. That is what Peter told me. So you have to be sure about your physical signs and be confident of what you say. So now, what was the clinical scenario before the before mid-1980s? Narada, I think all the senior pediatricians of my vintage will be able to remember there are several patients with measles before this measles vaccine came into the scene, and terrible complications like pneumothorax, we had to put intercostal drainage tubes, and some children died. And some patients, I remember very well, with typical measles rash and continuing fever went on for several weeks. Now, Kawasaki disease, it was documented by a Japanese doctor working for the Red Cross, whom I met in Yokohama together with Pujita Vikramasinghe when I went there some years ago. He had reported that we met this patient, Kawasaki. He was a Japanese doctor working for the Red Cross. He had reported that in a Japanese medical journal. And it took a long time for it to get into the English journals and for it to get into textbooks. And of course, at that time, there was no ultrasound to detect hydrops of the gallbladder and no echocardiography facility to detect coronary arteritis. So therefore, several cases of Kawasaki disease, which were mistakenly managed as case of measles, would have died at that time. That's the case of Kawasaki disease. You can see the magenta colored tongue, the rash, the palm erythema, and all those clinical signs. I think nowadays, I'm again told that Kawasaki disease, now earlier rheumatic fever was the commonest cause of acquired heart disease in Sri Lanka, but now I think Kawasaki disease has overtaken it. And Kawasaki disease for a long time have been the commonest cause of acquired heart disease in the West. But I think now in Sri Lanka also, I think Kawasaki probably has overtaken rheumatic fever, because now we hardly see cases of rheumatic fever, except sometimes I see patients in Anuradhapura from the northern province. And Dr. Raghunathan, who was the pediatric cardiologist in Anuradhapura a few years ago, told me that he used to see cases a lot in Jaffna after the war. And I think some of those patients came to Lael Ridge Hospital also later on, neglected cases. Then the Marfan Syndrome, you all are familiar with it. Tall and thin body with long extremities, arachnodactyly, hyperextensile joints, chest deformity, dislocated lenses in the eyes, and aortic echocardiography reveals aortic dilatation, prone to sudden death during exertion. That is why you have to diagnose it and treat it with propranolol or Resapine. Whenever I see a tall child, I always check for hyperextensible joints. I always do that. And if I suspect Marfan's, I always get an echo done to see how the aorta is. And if there's any any suggestion of any dilatation, then of course I treat them with propranolol to prevent sudden death. So there are neurocutaneous syndromes. Already I have referred to one, that is referred to. Then the neurofibromatosis, tuberous sclerosis, which I referred to, Sturge-Weber syndrome, ataxia telangiectasia, hypermelanosis of Ito, von Hippel-Lindau disease. Narada, you may be able to remember in Ward 1, we had a family with ataxia telangiectasia, Beta, Lena, and Vasanta. And when I went to England at the end of 1971, I took some of their blood samples because they have low IgA levels, and I gave it to Professor Soodhil. I met Professor Soodhil and asked whether he could do the immunoglobulins, because we couldn't do it in Sri Lanka at that time. Then he said, I'll have to have controls. I don't know. He said he doesn't know what the control values are in Ceylon. Then I got some control samples also from patients of similar ages, and Professor Soodhil kindly analyzed those results for me, those blood samples, and I reported this family. And one of them, because of the ataxia, fell in school and got a fracture of the shaft of the femur. And mind you, the femur in adult is harder than concrete. It's one of the most difficult bones to fracture. So that's these are the syndromes. Some time ago, I set a question in the DCH paper. Question was name 5 neurocutaneous syndromes and describe the clinical features of each of them. I did not say congenital. I said name 5 neurocutaneous syndromes. One candidate wrote about leprosy. Then I realized, yes, that answer is correct because I had not said congenital or inherited. And leprosy is an acquired neurocutaneous syndrome. So I gave good marks to that candidate. So sometimes when you set a question paper, sometimes the students give answers that the examiner has not thought of. It has happened to me more than once. Bright students will think of things that the examiner has not thought of. So if there are multiple lumps with pigmentation, then is neurofibromatosis, adenoma sebaceum in maxillary region and caffeoli patches, tuberous sclerosis, unilateral hemangioma of the upper part of the face, that's Sturge-Weber syndrome, ocular telangiectasia, ataxia telangiectasia, depigmented streaks and whorls, hypomelanosis or VIPO, and it has ocular angioma, von Hippel-Lindau disease. Now, when we were medical students, Professor Rajsuriya was the professor of medicine. And what we used to have no structured essays, we used to have essay type questions. And one of his favorite questions was examination of the hand as an aid to diagnosis, examination of the face as an aid to diagnosis, examination of the eye as an aid to diagnosis. And I had prepared comprehensive answers for each of the questions. The year we sat, the question was examination of the eye as an aid to diagnosis. When Professor Rajsuriya walked into the ward to ask whether there were any queries, I put up my hand and I asked him, does it include ophthalmoscopy or is it only naked eye examination? He took a little time and then he said it's only the naked eye examination. So handshake, if it is cold and clammy, you have to think of an anxiety state. If it is warm and moist, think of thyrotoxicosis. If it's a firm grip and the patient takes time to relax and you suspect myotonia congenita. If the grip is waxing and waning, then suspect Parkinsonism. If there are tremors, thyrotoxicosis or a cerebral lesion. Chylomicria, iron deficiency. Clubbing, either cyanotic congenital heart disease, infective endocarditis, or their pulmonary suppuration like lung abscess or pyorothorax or pneumothorax, or sometimes the clubbing is congenital. If there's erectronactyly, Marfan syndrome. Single palmar crease with a curved fifth finger, think of Down syndrome. Then examination of the tongue as an aid to diagnosis. If the tongue is pale, anemia, blue cyanosis, magenta, riboflavin deficiency, or Kawasaki. Beefy tongue, vitamin B12 deficiency. If it's a bag of worms, motor neuron disease. Jack in the box, as I told you earlier, rheumatic chorea. If it deviates to a side, then it's the 12th cranial nerve palsy. Examination of the eye as an aid to diagnosis. Ptosis, this is the question we got as for the medicine paper, and I remember getting a distinction in medicine the time that I sat for the exam. Myasthenia gravis, the 3rd nerve palsy, proptosis, cranial stenosis, if there's strabismus, 3rd, 4th, and 6th nerve palsies. There's differential diagnosis, jaundice, Beto spots, gutter pigmentation, keratomalacia. Now, of course, that's very rare now. Nowadays, it used to be very common. And if you got a case of gutter pigmentation with Beto spots, we give mecadose vitamin A straight away, because if you delay it, sometimes they develop keratomalacia by the next morning. It was a pediatric medical emergency. And we used to give megadose vitamin A stat if we saw gutter pigmentation or Beto spots. Pinpoint pupils, pontine hemorrhage, fixed dilated pupils, tonsil herniation, and cataracts, of course, many causes. Then examination of the face as an aid to diagnosis, various syndromes. Now, what is a syndrome? It's a diagnosis most often made based only on clinical features. Laboratory investigation may be used for confirmation of diagnosis. Like Down syndrome, you do chromosomal studies to see whether it is trisomy 21. That's obviously a Down syndrome. What is this? This is for the young pediatric registrars. Can you tell what this is? That's Marfan Syndrome, Cranial Stenosis. And this reminds me, when we have the cleft palate project going on in Gaul, once I was driving in my car with Michael Mars, and we passed the Sambodhi home for disadvantaged children. I said, Michael, would you like to drop in? And I turned my car into the premises, and to see a boy came up to the car, because several children came, and one came with bilateral proptosis. So Michael was surprised. He said, why hasn't anything been done for this child? Then when I made inquiries to see they were too poor, and because of this child's appearance, this child had been abandoned by the family. Then Michael felt very sorry. He said he'll go back and see whether he can raise funds to have this child operated. His name was Mahesh Mudita the Alvis, and he was from Matugama. He went back and he raised funds. Then on a subsequent visit, he took this child with him to England, and he wanted me to nominate a doctor to accompany the child. At that time, Padma Timbia Henti, now he's Padma Mudalige. Now she's a community pediatrician in London. I selected her to go to England with this boy. Now, the first night this boy was spent at Golf Face Hotel, and Michael was amused to see this boy chucking into the ice creams, and I think he has had about 3 ice creams that evening after dinner at the Golf Face Hotel. Anyway, Mahesh always was operated at Great Ormond Street with assistance from people as experts at Queen Square, and he came back with his face totally refashioned and with a hearing aid, because he had hearing loss also. Because of the change appearance, later on, the parents used to take him back to their home for holidays. He had completely changed his appearance. So that is what Michael Mars did to Mahesh Mudithirthi Alvis, a child with cranial stenosis at the Sambodhi home in Meghalaya. Right. Looks like a very wise man. What is the diagnosis? That's progeria syndrome, premature aging. I don't know whether this slide is good. You can see sort of a reddish flare over the maxillary area. So obviously, from what I have said, it's a case of Sturge-Weber syndrome. Then, of course, this child has a huge tongue. Now, it's not only Down syndrome. There are other conditions also with macroglossia, congenital hypothyroidism, Beckwith syndrome, and also the mucopolysaccharidosis. So there's a differential diagnosis. And when there are macroglossia, you must look for omphalocele to see whether there's omphalocele, then it's likely to be a Beckwith syndrome. That's fairly easy. Web neck. So that's Turner syndrome with the webbing of the neck. That's fairly obvious. And also the elbow joints, inwardly curved. Yeah, that is Soto syndrome with a big head. And here you can see the eyebrows almost meeting in the midline. So that is DeLange syndrome. You can see how the arms are and the genitalia. That's XY syndrome. That is Klinefelter syndrome. So a good physician, he treats the disease, and the great physician treats the patient who has the disease. That quote is by William Osler, a very famous person in medical history in England. Good physician treats the disease, the great physician treats the patient who has the disease. That is what he said. Now, I think Saroj would be very familiar with this name. David Lawrence Sackett and Joe Perro also would be familiar with his name. He said, half of what you learn in medical school will be shown to be dead wrong or out of date within 5 years of your graduation. The trouble is, nobody can tell you which half. The most important thing to learn is how to learn on your own. That is what David Lawrence Sackett, father of evidence-based medicine and collaborator of the Cochrane collaboration. That's what he said. So that's it, ladies and gentlemen. I hope you have enjoyed listening to my lecture. Now, this photograph was taken in 2016. The dates given are 6 June to 19 September. I was on an Alaskan cruise at that time, but those dates are not the duration of the cruise. That is the age of my beard and mustache. Thank you very much. Thank you very much for listening. Thank you.
Thank you very much, sir. Indeed, it was a very fantastic presentations with your experiences, true cases, and sharing with all of us, especially what is the importance of getting into this physical science, history, and examinations. Thank you very much, sir. If you have any questions, so we had almost 500 participants. It's exceeded, so our limit is 500. So I'm sure many of participants couldn't join this. If you have any questions, you can unmute and ask, or you can use a chat box. We can entertain for a few minutes.
I would welcome questions. Sorry, I couldn't hear.
This is Udaya, sir, from Anuradhapura.
Yes, Udaya.
It's nice to hear, sir. You are doing a very fantastic, very attractive lecture.
Yeah.
This is not a question, sir. It's just a suggestion. So, to make a kind of a book or some documented format of your experience for the future graduates, medical teachers, and even for us.
Well, Udaya, a lot of students have told me that I should be writing my autobiography. So I am writing my autobiography and I almost completed it, but now there's an additional section to add. You know, the ongoing saga, some of you are aware, because I think to tell the listeners, I am in between. I had a coronary angiogram done on Friday, and on Thursday, I'll be having open heart surgery for replacement of my aortic valve, which is sclerosed. I have got severe aortic stenosis. So it's a sandwich with me in the middle and a coronary angiogram on one side and open heart surgery on the other. But I had agreed to give this lecture and under no circumstances would I back down. So Sujiva, yes, I will think, and some of these would be in my autobiography. Thank you, Udaya.
Okay, welcome, sir. Long life, sir.
Yeah, I'm sure that it was a very comprehensive presentations and over hundreds of diseases, syndromes were covered, especially how should we related to these syndromes and the diagnosis with clinical symptoms and physical signs. So actually I didn't reveal that, but as revealed this, yeah. So that is shows his dedication. So following angiogram, this following day, he just confirmed, yes, I'll do this. So that is very important, very encouraging to our juniors as well. So other thing is the presentations on time. So all these things are very important to learn. So I think this is a time to conclude these presentations. So still we have over 400 participants. So I would like to thank Professor Lamabadusuriya. I'm sure you will agree if I tell him, as we all simply introduce him as King of the Pediatrics. So today also he proved that he is the King of Pediatrics in Sri Lanka. So thank you very much, sir.
Yes, Shaman, you referred to me as the King of Pediatrics. Now let me tell you all. You see, when I retired from Colombo in 2008, I had 3 telephone calls from Dr. Neville Fernando. First time he gave me a call and asked me to come to Saitam. I said, there's no hospital, there's no point in my coming. The second call came 2 years later. He said, then he said, there's a beautiful hospital. I said, yes, there's a good hospital. But unfortunately, I have a problem with my family because my wife, Buddhika, had developed an ovarian cancer. So for family reasons, I can't come. She lived only for 2 years. The third call came, and by that time, my friend Anuruddha Padini has invited me to come to Rajarata to teach the students. And because they were lack of teachers, so I thought that was a greater national need. And I told Dr. Neil Fernando, now I had decided to go to Rajarata. I'm sorry, I can't come to Malabe. And if I decided to go to Malabe, I live in Gothamilli and Borel, I could have driven there and he would have given me any allowance I wanted. Instead of that, I used to get up at 4:30 in the morning, go to the Fort railway station, get into a train and travel to Anuradhapura in the Intercity Express and return on the Friday. I started going there in April 2015. At the end of the appointment, the students had a party, speeches, gave me a nicely wrapped parcel. I opened the parcel, there were 40 letters. And only about 5 have signed. I returned it and I told them, please sign your names, write your names and return it. I took the bundle, I went to my room. All these students came, lined up, touched my feet and worshipped me, except for 4 or 5 students who are Muslim students. When I opened the package, first letter says, dear sir, I wonder what merit I had done in my previous birth for you to decide to come to Rajarata to teach us. Another letter, dear sir, it is a privilege for us to be taught by the king of pediatrics in Sri Lanka. Few more letters, dear sir, it is a privilege for us to be taught by the god of pediatrics in Sri Lanka. Now the value, I have those letters, the value of those letters cannot be measured in rupees and cents. So that is what the Rajarata students think of me. Now, Buddhika was a very religious person. She used to go to Anuradhapura very often, most of the time without me, sometimes with my elder son Shamin, because he was a spiritual minded. Her visits are so frequent. One time she wanted to buy a house in Anuradhapura. And I told Senaka Gunatilaka to look for a house in Anuradhapura. And recently, I think when I spoke to Senaka, he remembered that. Now, if Buddhika was around, I would not be living in Colombo. I would be living in Anuradhapura and doing a full-time job at Rajarata if Buddhika was around. And she would have been extremely happy visiting all those Atamasthana in Anuradhapura. So wherever she is, I believe in rebirth. Wherever she is, I think she must be very happy about what I am doing in Anuradhapura. And maybe it is fitting that I developed the symptoms of I became unconscious inside a car and recovered very quickly. It happened in Anuradhapura. So maybe that is my destiny. Thank you very much.
Thank you, sir. Before concluding this, I'd like to read a message sent by Dr. Mahendra Gonsal Korala. So it's very interesting. He said, the prime duty of a doctor is to do his or her best for the patients and not for any personal gain. The beauty of medicine is that a good doctor gets a lot of satisfaction from his process, but also do not underestimate the pleasure you gain by making a correct diagnosis. It is even better if you first make a clinical diagnosis and enjoy the happiness when it is confirmed through investigations. Prof. Lama illustrated this point beautifully. It's very beautiful writing. Thank you very much, Dr. Mahendra Gonsal Korala. So all this illustrate the beauty of Professor Lamabadusuriya's life. So finally, on behalf of Sri Lanka College of Pediatricians, so we would like to wish you speedy recovery and long lives, and we all are waiting to read your autobiography. So thank you very much, sir, for giving this presentation as well as inaugurating our new lecture series, Vintage Pediatrics Pearls, as well as we saw some seniors are joining here. So we will come back to you also, sir. Few of the seniors are here. So it's very good start inaugurations, and it reached the 500 maximum participants number of this our Zoom subscription. So this is the time to conclude this. So I'd like to thank all the participants, senior professors, senior consultants, as well as juniors, medical students from Sri Lanka as well as overseas. So it's very interesting and encouraging your participation. So we will arrange the next lecture the 3rd Sunday of next month. So till then, have a nice time. Good night. Have a nice day. Thank you very much.
Thank you very much, Shaman. Thank you very much, Channa. Thank you for the listeners also. Thank you.
Thank you and good night.
Sir. Good night. Thank you.
Thank you, sir.
Signing off.
Nice to see you, sir.